being here on this wonderful Saturday with beautiful weather outside, so I'll try to make it worth your while. Today, in 20 minutes, I'm going to try and give you a very practical overview of depression and anxiety issues when it comes to inflammatory bowel disease. So I'm going to do it in the way of going over a number of questions. I'll go through a number of questions. We'll go through them one by one, and really very practical questions. So overall, what is the relationship of depression and anxiety to inflammatory bowel disease? What is depression? What is anxiety? Because I think the terms are thrown around a lot, but it's difficult to define them when it comes to a medical definition. What is the extent of the problem? How do we screen it? How do we diagnose it? And how do we treat? So very practical questions. So let's start with the first question. What is the relationship of depression and anxiety to IBD? So I could give you study after study, but what I decided to do is really, I think the question in most people's minds is it related? Is it not? Okay. How big is the relationship? And is it causative? Okay, so I'll go through those one by one. So the rate of anxiety in inflammatory bowel disease has been reviewed recently in the Journal of Inflammatory Bowel Disease in 2009. It was a really nice review of a number of psychiatric issues in IBD. And it was found that people who have IBD, if you combine most studies, have about 5 times the rate of the normal population of developing an anxiety disorder. So we're not talking about someone who just has a little more anxiety than the average person. We're talking about developing an anxiety disorder that leads to dysfunction, that is diagnosable psychiatrically. And I'll go over what that means in a second. What about depression? So the rates of depression, similarly in IBD, amount to about 3 times the normal population. So the normal population rate of depression is about 10% in terms of prevalence, and it would be 3 times that in IBD. Now, is there a relationship between having depression and anxiety and higher rates of disease activity or relapse? That's a little bit harder to prove. I think in general, to design a study to prove that is very difficult because there's so many confounding factors. But authors in this review felt that there's enough evidence. There was a recent review showing that, in fact, having anxiety, specifically anxiety, more so than depression, led to more relapses over time. And this was a study which actually looked at, it was a prospective cohort. So this is the best kind of study you can do beyond a randomized controlled trial. You take a cohort of people and a control group and you follow them over time, and you see what happens. And if you can match the 2 groups, that's even better. So some results from the studies that point to this. This is a study that looked at disease activity in IBD and its relation to anxiety. Now, when we talk psychiatrically about anxiety, we talk about state anxiety and trait anxiety. What is the difference? So if you had an exam in a week, and it's a major exam, and you're very anxious, we call that state anxiety. You're anxious because of the state you're in. Trait anxiety is anxiety without a clear trigger. It's there, it's a trait within you. And so for us in psychiatry, what's more important, because anxiety is actually not always a bad thing. It's sometimes a useful thing. Having a cough is almost always bad unless you're clearing fun. But in psychiatry, having a bit of sadness is actually helpful because you would not know what happiness feels like if you don't feel sad sometimes. Having a bit of anxiety is useful because you wouldn't have fire under your feet to study or to get out of the way of a car coming towards you or jump away from a snake that's about to bite you if you don't have a little bit of anxiety. And so what's important to us is trait anxiety to the level that is beyond the level needed for functioning. And that's been shown very clearly both in ulcerative colitis and in Crohn's disease. So you have higher rates of both state anxiety, which is logical because if someone's very sick, they're going to be anxious about being sick. So that's the state. But you also have higher levels of trait anxiety. And there's ways to test for both in terms of psychometrics. Now, this has been shown both in IBD, in both major forms of IBD. And what's interesting is that when you take people who have active disease and those same people, when you get to remission, those levels of both state and trait anxiety go away. Okay? So there's a state anxiety because you're ill, at the time you're ill, but there's also a trait anxiety, an anxiety unrelated to the illness, that is elevated when you're sick and decreased when you're not. And that speaks to that the stress sympathetic nervous system and the HPA axis is in overdrive when you have an inflammatory condition like inflammatory bowel disease. And we believe now that a lot of psychiatric conditions like depression and anxiety are also driven by these same mechanisms. So this is an illustration of that. In anxiety and depression and stress, the brain and body are both affected. So if you look at this, that laser is better. Okay. So if you look at the brain, it's we often think about it almost as disconnected from the rest of the body when it comes to control, but in terms of chemicals affecting it because we have a blood-brain barrier. But in fact, stress hormones, cortisol, sympathetic drive all affect the brain and affect the body. And so one of the most replicated findings you find in psychiatry in terms of biomarkers is that people who have depression, people who have generalized anxiety, have a failure to suppress in the dexamethasone suppression test. So normally, if someone doesn't have an illness, if you give them dexamethasone in the morning, it'll suppress their basal levels of cortisol because of the feedback inhibition. If someone's depressed, it's actually the feedback inhibition has become dissociated. So you give them dexamethasone, the cortisol fails to suppress. And so what's happening is that these stress systems are in overdrive. They're affected, the brain is affecting the body is affecting the brain. And that's what we believe is happening. That's why you get both state-enteric anxiety and higher levels of depression in this disease. So let's get into a little bit of definition. What is depression? What is anxiety? And remember here we're talking about the psychiatric definition. If you talk to anyone in the street and said, what is depression? They would tell you that it means sadness. Okay? But depression, when it's a medical syndrome, goes far beyond sadness. If you ask anyone what does anxiety mean, they would tell you worry. Okay? But anxiety, when it's a medical disease, goes far beyond that. There's a number of other symptoms. So let's review them. This is the way we diagnose in psychiatry. We have a manual that we use because we don't have as many biomarkers as internists and other medical specialists, but we try to be very strict with our criteria, like rheumatologists used to be before they had biomarkers. And so our criteria for depression is in fact very strict. In order to diagnose major depressive disorder, so clinical depression, you have to have 5 of 9 features. You have to have them for most of the day, for most days, for at least 2 consecutive weeks, and it has to affect your functioning, either in terms of your academic functioning, or your occupational functioning, or social functioning. So even if you have 5 to 9 symptoms for most of the day, for most days, for 2 weeks, if you don't have this function, it's not medical depression. Now note, in fact, and for me to prove to you that depression that we're talking about medically is not the same as depression that anyone talks about in the public, is that you can actually diagnose the disease depression, major depressive disorder, without having the symptom depression. So let's go through the symptoms. These are the symptoms of the clinical syndrome depression. Okay? So you have 9 symptoms. You have to have 5 for most of the day, for most days, for 2 weeks at least. Now, one of those 5 at least has to be one of the first 2 criteria. You either have to have decreased mood, depressed mood, or decreased interest. So you can diagnose depression, the clinical syndrome, by having decreased interest, but no depressed mood, along with 4 of any of these others. So in fact, you can diagnose depression without having sadness. And I see it all the time. So people tell you ask them, are you sad? No, I'm not sad. But I can't ever feel happy about or interested in the things I used to be interested in. I would say those are half of what we call clinical depression. And in fact, depression is not one thing. We have all these different subtypes of depression. And this affects, both the pathophysiology is a little bit different in each time, and the treatment is a little bit different in each time. I think in the future, probably 10, 20 years from now, we'll realize that when we were talking about depression, we were actually talking about 5 or 6 different diseases, much like gastroenterologists in the past used to call everything inflammatory bowel disease, and now we know there's Crohn's and ulcerative colitis and some things in between. It's not my area of expertise, but I'm sure what I hear from my colleagues is that's what's happening. I think we're at the start of that in psychiatry. Now, the point is, we're starting to define things like anxious distress, so we have a specifier. This is a worse form of depression. If you have depression mixed with anxiety. So if you have depression, those 5 of 9 symptoms, plus you have some of these symptoms, most of these symptoms for the majority of days, feeling tense, feeling restless. So you notice that depression actually has physical manifestations. Feeling like you have a lack of concentration, so you have cognitive manifestations. Fearing that something awful may happen, emotional manifestations. and feeling that you might lose control. So these are social manifestations. So really, when we talk about depression and anxiety, why we talk about them together is there's a lot of overlap between them. And again, I'm talking about the clinical syndromes. So if you look at depression, it includes all of these conditions, but these in the middle overlap with something like generalized anxiety. So the things that are specific to depression are things like depressed mood, anhedonia as a lack of interest, appetite disturbance, worthlessness, feeling suicidal. If you look at generalized anxiety alone, you get a lot of physical symptoms. Feeling worried is a cognitive symptom, but muscle tension, palpitation, sweating, dry mouth, nausea. Those of you who've dealt with a patient who's had a panic attack, you've probably seen some of these symptoms. And the patient comes in worried that they're having a heart attack. But you have a lot of symptoms that overlap. Anxiety, sleep disturbance, feeling agitated motorically, having difficulty concentrating, being irritable, being fatigued. This really bridges between the two. And what we see in a condition like inflammatory bowel disease is you probably see the whole picture. You probably see some manifestation of both sides at different points in the disease. Anxiety is commonly comorbid, up to a 90% comorbidity rate with any psychiatric disorder, and almost 65% with major depression. So 65% almost of major depression will have an anxiety component that's very severe. So this is kind of a medical definition. We come to our third question. What is the extent of the problem? Well, the WHO ranks psychiatric illnesses as the most disabling illnesses on the planet. This is the projection for this decade, and what the WHO ranks, according to disability-adjusted life years, is that 5 of the top 10 most disabling illnesses on this planet in this decade are going to be psychiatric illnesses, with number 1 being depression. You know, it's outweighed now cancer, it's outweighed heart disease, it's outweighed anemia even, and it's very logical because our societies have changed, and our societies have changed in a way that the focus of all our jobs nowadays are cognitive. Most of us are in the healthcare industry, and our jobs rely not on our physical strength, but on our cognition. But if you look at someone, the person who installed my computer just now, okay, or the person taking this presentation, or the hotel worker, or the caterer, or someone who works in sales, or pharmaceuticals, and so on. Everyone today, most jobs rely on cognition. Cognition, social interaction, and controlling your emotion. And so it makes sense that because we moved on from industrial and physical ages of hunting and gathering and farming and factories to more of these cognitive jobs, then the most disabling illnesses on the planet are those that are going to be cognitively disabling. We know that mood disorders exist in an ecosystem of a lot of other different disorders. All of these disorders listed here occur at higher rates than would be expected by random chance when you have a mood disorder. You have this arc of metabolic conditions. You have an arc of other psychiatric conditions, and you have some pain conditions. And these are studies adjusting for all other factors. Really, mood disorders put you at a risk for all of these other conditions. So that's really the clinical cost. What about the personal, the social cost? Well, all of us spend about 1/3 of our lives asleep. Someone who's depressed spends about 1/3 of their life, asleep. What about the rest of their life? What proportion of their waking life, because depression is a chronic condition and it's a relapsing remitting condition, what percentage of the remainder of their life that they're awake is spent in depression? It's about 20%. 1/5 of their waking life is spent in depression. And this is even with optimal treatment. So really it's a very difficult illness to treat. It's a very chronic illness. And what happens is if you don't treat it fully, this is a survival analysis, and as the line is going down, it means people are relapsing into future episodes of depression, because depression comes in episodes, it comes and goes. And what happens is if a person is fully asymptomatic at the initial period of recovery, they have less relapses over time than someone who is not initially asymptomatic. Well, what strikes me too in this study, which was a 75-week prospective cohort, long study, was that even the blue line, even people who were fully asymptomatic, were treated excellent care, got back to full remission. Over time, most of them relapsed. And definitely someone who has an inflammatory condition is going to relapse more. So beyond the theory, let's get to, well, what do you do? How do you treat? First of all, you have to establish the diagnosis. So how do you screen, first of all? And to establish the diagnosis, there's a number of screening scales. I'm going to show you one of them after I get through these principles of management that you can use very easily. And it's the scale that's recommended now by the WHO. So first is establishing the diagnosis. You don't always need a psychiatrist to establish the diagnosis. It's not very difficult now with current screening skills to actually screen for depression. If it's getting complex, then you can consult a psychiatrist. But I am a believer that any MD should be able to treat mild to moderate depression, even pharmaceutically. Okay? Especially people who work in areas that is highly prevalent, like rheumatology or GI or so on. So you shouldn't be scared of treating it. And in order not to be scared of treating it, you have to feel assured as you're diagnosing it. The second thing you have to do after you've diagnosed is to do a risk assessment. Is this someone you can follow up in an outpatient clinic? Or is this someone that needs to see a psychiatrist immediately? Or is this someone who needs to be admitted immediately? And so the main risk assessment you're looking at is harm to self and harm to others. So you have to ask the question. You have to ask, because in front of life, have you felt hopeless to the point that you don't want to be living anymore? You have to ask those questions. Don't be shy of those questions, because sometimes the patient wants to tell you, but is waiting for you to ask. And they know that you're going to push them into help, but it's very hard. Now, whenever I say this, a lot of doctors ask me, well, if I ask them, I might implant the idea in their head. It was never there. That's actually been studied, and studied very well, and that never happens. Good qualitative research has shown that no. In fact, it's kind of like smoking. You know, if you ask a patient, do you smoke, you're not going to implant the idea to smoke in their head. But it's been shown that just asking a patient if they smoke and telling them you should probably quit, you get quit rates doubling. Okay? So you really have to, if you suspect depression, ask, do you feel suicidal? The third principle of management is that you have to, just like you adopt a chronic disease management framework and philosophy when you're treating inflammatory bowel disease, you have to use that same philosophy and framework for a disease like depression. Sometimes people forget that because it's a very acute condition when you first see it. But really it's a relapsing remitting disease over time. So you have to treat it acutely, but also watch out for relapses in the future. The fourth principle is if you have, say, inflammatory bowel disease and depression, or you have psoriasis and depression, or any kind of major illness and depression, do you do concurrent treatment or sequential treatment? What do people think? Do you treat both at the same time, or do you treat one and then the other? Well, it's been shown that you should treat both at the same time, because the depression will make the medical condition worse, and the medical condition will make the depression worse. So in most cases, you should treat both at the same time, initiate treatments for both. That you have to use medication. There's other treatments other than medication, but you should initiate treatment. The last major point is you should use measurement-based care, which means just like if you have a hypertensive patient, you check their blood pressure and monitor over time and see how it's responding to the treatment, you need to be measuring your patient's depression over time, which is actually the same scale that you use for screening and diagnosis. So this is the PHQ-9 scale. There's a number of different scales for depression, but this is definitely by far the most suggested one. And there's an Arabic version. If you just Google PHQ-9 Arabic, you'll find it. And this is something that actually screens for depression and gives you the severity. You can classify it into mild, moderate, and severe. And it screens for the suicidality as well. Generally, the patient should do it themselves. It's a self-filled scale. Now, let's get into the treatments. So, what about antidepressants? There's so many on the market, so which one should you use? Well, there's a general principle in pharmacology, in psychopharmacology, that the best medication is the medication that the patient is willing to take. One of my mentors, when I did a fellowship in psychopharmacology, said to me once, a very important phrase I always remember, which is, no medication in the world is going to work if the patient is not sticking it down their throat. Okay? So, you really have to have a medication that has low side effects, that has low interactions, especially in a disease like IBD. So this was a study that's non-industry funded, not funded by any pharmaceutical industry, done by a very well-respected scientist in our field named Suwaidan. And the mathematics were done by PhD mathematicians, and it's what's called a multi-drug meta-analysis. It's a new form of meta-analysis, where you take multiple drugs, comparators, and compare them. So what he did in this, after he got all the scores, he gave fluoxetine, which is Prozac, a score of 1 on acceptability and 1 on efficacy, arbitrarily. And then, based on the results from the meta-analysis, he ranked all the other antidepressants compared to fluoxetine in terms of their efficacy, which is this way, and their acceptability, which is this way. And he found that 4 medications came out in the top quadrant, which are highly acceptable to patients in terms of side effects, and highly effective. And they are escitalopram, which is Cipralex, sertraline, which is Zoloft, bupropion, which is Wellbutrin, and citalopram is off the market now, actually. So the makers of citalopram are also the makers of escitalopram. So they've canceled this one, and it's been replaced by this one. So really you have 3 in the top. Now, there is a deficiency in this meta-analysis that there's two newer antidepressants that are not included. There's one called Pristique and one called Valdoxan, which are not included in this meta-analysis. I don't know where they lie. Pristique is really the active metabolite of venlafaxine, which is Effexor. And Effexor is a highly effective antidepressant with lots of side effects. And so when you get the active metabolite, theoretically what should happen is you should keep the same efficacy and go up on the tolerability. But how far up, we don't know. Now, so in terms of my clinical expertise, I would think the top four are escitalopram, sertraline, bupropion, and my view is probably the best venlafaxine has moved up here. So, what about an inflammatory bowel disease? The best evidence is for Cipralex, which is escitalopram. Why? Because it has very few drug interactions, very few GI side effects. Sertraline, which is actually an excellent antidepressant, I use it a lot in non-IBD patients, has been shown to have the worst GI side effects in IBD. So Zoloft is probably the last choice in IBD. Cipralex is usually generally the first choice. When should you use an antidepressant? The antidepressant should be used if you have anything that's moderate or moderate to severe depression. If you have a mild to moderate depression, then you can think about other treatments first before you go to pharmaceutical treatment. Pay attention that some medications can cause weight gain over time. Okay? So if you look over here, paroxetine, which is Seroxat or Paxil, amitriptyline, which is Elavil, or in Kuwait it's called Triptazole, mirtazapine, Remeron. So these are very high in terms of their weight gain potential. If you look at escitalopram, sertraline, which we just talked about, their weight gain potential is very minimal. And bupropion, Wellbutrin, is actually low, helps patients lose weight. Let's skip that. You have to pay attention to deficiencies. We know that deficiencies occur. Vitamin B12, zinc, vitamin D, and folate have all been linked to depression, not as causative agents, but as worsening it. And I would imagine, the experts are here, but I would imagine that it's much more likely to have a deficiency in a vitamin or mineral if you have a disease like IBD. So I think pay attention to that. Zinc is a relatively new one. We knew about folate and vitamin D and B12 for a long time. But zinc, this was an Iranian study from a few years ago, 2013, and it showed that actually a third of patients who have depression, a third of females who have depression have zinc deficiency. And if you actually replace the zinc versus placebo, they do better over 90 days. Can you use anti-inflammatories for depression? This is, new evidence. This is a forest plot of a number of different studies, and the end result is probably yes. And there was a new study recently last year showing that using infliximab in patients who have depression, who don't have IBD, okay, just giving infliximab to someone who has depression, does work if the person has a high CRP at baseline. Okay, so if someone who's depressed has a high CRP, even if they don't have an indication to take infliximab, I'm not saying go and give infliximab to depressed patients, but this is just, really proof of concept work. This was a small placebo-controlled trial, double-blind, very well-designed trial, funded by the National Institute of Health, and it showed that infliximab can help depression, but only if your CRP is elevated. So that probably means there's a subtype of depression that involves a lot of inflammation. Now, we know that people who have IBD, who take an anti-inflammatory or anti-TNF, and the disease goes into remission, as I showed you earlier, remission leads to less depression, less anxiety. So there's a link there. There's new treatments. There's a treatment called RTMS, which is magnetic stimulation therapy. This uses no medication. It's very specific. You give specific magnetic impulses to different areas of the brain. And this may be an ideal treatment for people who have a lot of medical illness and can't take a medication. This is not available in Kuwait yet, but the first device hopefully will be coming to Mubarak, that we've gotten approval for it, hopefully in about 6 months. Hopefully, all the process goes well, but we've gotten the final approval on it, and it's coming to Mubarak soon, inshallah. Lastly, physical exercise is very, very important. This is a study showing that physical exercise corrects a lot of the different deficiencies that occur when it comes to bipolar disorder, but also in unipolar depression. And lastly, I wanted to show you one small video. It's only about a minute and a half long, speaking about a new kind of psychotherapy that a lot of people can apply called mindfulness. So I hope that the sound will be here. Let me see. Use the mic. So this is a long video. I'm only showing you a little bit of it. But I love that last quote where it says, next time you're in the shower, check that you're in the shower alone. Because you might have 50 people with you in the shower because your thoughts the problem, with stress is that you're either fixated on past regrets or on future fears, and we're not living in the moment. And this is something very chronic. And this is a new wave of psychotherapy that's been very, very helpful to people. And you can train in it. You can go to a place like a retreat where you train in it, and you can have online training in it. And I think it's very helpful for patients that apply. So to give you the final slide, really, the treatment of depression and anxiety is a blend between the biological. This is a model from Engel, who's actually an internist, not a psychiatrist, back in 1977. And it really speaks about that you have to look at the biological, the psychological, and the social factors in treatment. So the treatment really lies right there. It's not there alone, or there alone, or there alone. And thank you very much. This is the logo for our new service at Mubarak, and that's the website if you need to refer patients if they're part of the Mubarak catchment area. And thank you very much to Dr. Yasser and Dr. Bilal for the wonderful organization, the other team members as well, and thank you for inviting me.
Thank you.